Good morning, everyone. Thank you, Edwin, for the introduction. I am Professor Manoj Sivan. I am the president of British Society of Physical and Rehab Medicine. Just going to. It is a great honor to ask me to give the Sir Byron Bramwell lecture. Sir Byron Bramwell himself, a great physician and inspiration for all of us, ex-president of the RCPE. So in my talk today, I'm going to give you a brief overview about the specialty, what we do, what has been our past, and what plans have we got for the future. And hopefully it'll give a good insight into our current situation in the UK and overseas as well. So I've got a couple of roles which I've listed there. I am a clinical academic based in University of Leeds and the Leeds NHS Trust. So rehab has suddenly become very important in the last couple of decades, I would say. I'll talk about why it is the third new indicator of health. And I talk a little bit about our history, our training structure, how can aspiring doctors train in our specialty, what are the things we currently do, and two important projects, the Rehab Medicine Expansion Proposal 2016 and the Inform Project of 2023, which is the kind of under the banner of the International Society, and more importantly, the WHO Rehab 2030. I was specifically asked to talk about this because this sets the vision really for rehab and where we come in this vision of WHO, and then sum up by talking about our future. So let's talk about indicators of health. So a person with stroke comes in, needs proper investigation. You pick up a carotid, you put the patient on appropriate treatment. You pick up other conditions which need dealing with, like the carotid atheroma and other complications which the patient has of renal failure, chest infection. So the primary aim is to deal with these medical complications and reduce the morbidity. And obviously, you want to avoid the other outcome, which is mortality, which is death. So any pathway, any healthcare service, any department focuses on those two outcomes. How are we doing in terms of morbidity? How are we doing in terms of mortality? And you want to keep both of them low. So those are considered as the traditional indicators of health. But what about the outcome of these people, of our patients, when they get discharged from the ward? How important is their function in terms of at discharge? Are they able to walk as before? Are they able to do their activities of daily living as before? Are they communicating as before? And are we able to integrate them back into their work, into their family life and social life as it was before? So all that is equally, or in fact, even more important than the other two indicators of health. And this is why WHO is now mandating on functioning being the third indicator of health. And every health service or every pathway or country has to actually provide some stats on functioning as well. And it will soon become a mandatory indicator, and it'll be part of the M&M meetings which we have. It's actually got to be the MFM meetings where we talk about functioning. And this is where rehab comes in. How are you going to improve a person's functioning and their outcomes? This is when you have a team of rehab professionals working with the patient to improve their function. So this is the team. It's just a rough picture there with the different professionals involved. There are a lot who have not been listed. We are the rehab physicians in the red. And any physician, for example, a cardiologist, a gastroenterologist working with their patients could also be in that rehab role. But there is a need for that specialist training to understand how do we work on improving function? What are these different health conditions to deal with when you talk about rehab? Because a rehab physician actually doesn't deal with a specific organ. They work across organ systems, and they're more like a generalist, even though they are a specialist in rehab. In terms of the organ system, they are more generalist. So a particular organ-based specialist like cardiologist or gastroenterologist or a neurologist, they need to have that sort of training of understanding the concepts in rehab, and hence there is a need for training in rehab medicine to be able to provide that sort of care and be part of the rehab team. Not to forget, I've highlighted researchers there because they drive all the evidence behind rehab, and all the basic science on the clinical rehab research has to be integral part of the rehab process. So rehab medicine, as I said, we as medics are concerned with improving the function, and we apply our medical skill in diagnosis and understanding the health conditions which actually come in as complications when the patients are in the hospital or in the community. How can we diagnose these comorbid conditions, reduce the impairment caused by them, prevent all the complications, and work with the rest of our team in improving the patient's function. So it's a slight different concept than just managing the acute complications and making sure that the patient is out of that sort of danger zone, and the patient is alive. So let's look at when we talk about disability, there is a concept called disability adjusted life years, where you can work out, well, what is the quality of life of a patient because of that health condition? And you work out the patient's life expectancy. And then given that the patient's quality of life is not the full, is reduced, you then calculate a disability adjusted life year for the years the patient is going to be alive, because that is really a true indication of the burden that condition has caused to that individual for rest of his life, because most of these are long-term conditions. So when you look at the burden of the top conditions which cause disability, the global burden of the census, which is done every often, it's generally published in the Lancet. And the last census, if you look at the top conditions causing disability, have been listed there, and you can see there's no surprise for every census which is done in the GBD. The top conditions are pretty much the same. The only one which is new probably in 2021 census is COVID, because of the huge mortality and also the disability it causes in terms of the long-term outcomes, or the long COVID. So musculoskeletal problems, road traffic injuries, stroke, respiratory infections, falls. So you can see pretty much these are the ones we would have thought to cause this long-term disability to patients. So as a specialty, we would like to be involved in managing all these patients long-term and improving their function. We do that very well in, for example, people with neurological conditions. We have services right from hyperacute rehab to level 1 for patient with highly complex needs, level 2 secondary services for complexity, which is one level below the kind of the hyperacute rehab, and then level 3 is in the community and other general rehab services, which are quite important to do that final step of integration piece before the patient can go back to their chosen place of destination. So that's sort of providing seamless rehab care across the tiers of the healthcare system, and we do that quite well for people with neurological conditions. In terms of the training, as we just discussed about the various conditions which cause disability, which is quite varied, and we've kept even our training structure quite varied, that people from internal medicine training, surgical training, general practice, psychiatry, once they've had that core training, then they can enter the specialist training in rehab for 4 years, and then they can go on to become consultants in their chosen area, because again, the field is quite broad in terms of what you want to specialize in. The primary subspecialties we currently have, even though not not officially called subspecialties. The subspecialty areas we've got is neuro rehab, spinal cord injury rehab, musculoskeletal rehab, and amputee rehab. A little bit about our history. So as a specialist society for the specialty, the British Society of Physical Medicine started in 43, and this was to do with colleagues coming together who looked after soldiers coming back from the war and looking after their injuries and the disability it caused. And then that slowly evolved in the 50s to include rheumatology, which is to do with inflammatory musculoskeletal conditions. And then in the 70s, there was this massive need for people from both neurological conditions and musculoskeletal conditions, primarily to look after the disability aspects. And the word rehab replaced actually physical medicine. And then in the 80s, because clearly inflammatory MSK conditions was definitely becoming a separate specialty. So then the society split into Society for Rheumatology and Society for Rehab Medicine. And that is the start of our journey, basically, in the 80s. Over the last 2 decades, there has not been a dramatic increase in our workforce numbers. You can see we are right at the bottom, the green line, in terms of our numbers when compared to other specialties in the UK. I mean, some specialties like cardiology and geriatric medicine have almost a threefold increase in the last couple of decades because of the need. And even though there was need, somehow I think we have not seen that amount of growth, and that was a cause of concern for us in the specialty. And we started looking also outside. What is the situation in terms of the physical rehab medicine doctors in Europe? Our workforce is almost like 20 times less than many European countries. And if you look at even European average, we are about 10 times less. So if it's 3 PRM doctors needed for 100,000 population, we are 0.3. So 10 times less than the European average, what is needed for looking after people with long-term conditions and disability. Now, this was really a cause of concern for us, and a group of us started looking at, well, what is the reason? What is the reason for one, the low numbers, and two, the lack of growth, given there is so much need in terms of all the conditions which cause disability. How is it that our specialty is not expanding and not growing? And we found that our areas of practice was predominantly around brain injury, spinal cord injury, amputee, and some MSK, as I said. But there is a huge field of MSK, and pain, which is the number one cause of disability globally, as we also saw in the global burden of disease census, which is actually not covered by us. And then stroke has become a specialty of their own, and we don't get involved that much in cancer rehab and cardiac rehab and so forth. So we identified that our workforce issue was related to the scope, really, that we are very narrowly focused in some conditions which cause complex, severe disability, predominantly inpatient in hospitals, and we are not sort of visible in the space outside that where there is huge disability as well. Now, if you look at overseas, in the Europe or in the States, where the specialty is very popular, is one of the top 10 specialties, and constantly is one of the top 10 specialties in the States, is because the breadth of what they do. And the PM&R or PRM specialty actually provides that cover across all these conditions in terms of long-term management and managing conditions. So that is the crux of the problem we have in the country, which is related to the scope of practice. So hence we wrote a proposal of a rehab medicine expansion proposal, which then got published. And this was basically meeting all our colleagues across the country and thinking of ways of how we should work to expand our scope, and eventually to increase our workforce numbers, because with the small workforce numbers we have at the moment, we're not able to meet the rehab needs of people across all those conditions we talked about. Um, um, and the argument was, well, is the name of our specialty or society linked to workforce numbers? Because this was, again, there was a lot of tension, as you saw also in our past, the slide on our past, that we dropped the word physical medicine and then we stuck to rehab medicine. Was that the cause? And there's a lot of ongoing tension within the society among colleagues, whether actually the name has to do anything with the numbers. But then we did this interesting exercise where we actually looked at workforce numbers across all these countries globally, and we also looked at the name, because there's only few countries which actually have got the name rehab medicine. Predominantly the name is PM&R or PRM. And what we found is very interesting, as you can see in those graphs there, that when the name is got actually the physical element in it, the workforce numbers are higher, and the scope is also much wider. So it happens to be that the name provides a better broader scope and an increased workforce, which enables us to address actually the rehab needs across all those conditions. So hence we put this to our members for voting, and then the majority preferred to actually align ourselves in terms of the name to other countries, and hence in 2022 actually we change our name to physical and rehab medicine, just to bring back the term physical. Now, whether that does the trick of expanding our scope and workforce numbers, only time will tell. We also have written about this because we also felt that there is some confusion in terms of different names our specialty is called in different countries. As I said, PM&R, PRM, RM. So it's quite confusing. I think there is a lack of identity, and hence we said we need a uniform global name for the specialty of physicians working in rehab. And that led on to the INFORM project, which we did under the umbrella of the International Society of Physical and Rehab Medicine, where this was led by us from the UK and myself, and I'm the chair of the task force. And what we wanted is this uniformity across all the countries, so that we could agree on a uniform name, a uniform scope, training, curriculum, fellowship, and how we can influence commissioning so that our brand is easily understood by our colleagues, the commissioners, juniors who want to get trained in the specialty, and more importantly, the patients. Really, I think the patients would like to see that sort of uniformity in not only the name, also the scope of practice and that identity which we need to have, and that relationship we want to have. So the first project we did was establishing the name for the specialty, and then we've also done another project on scope, and that will go on. So every year we will do a cycle of consensus on various aspects of the specialty. So just to quickly touch upon what we found is PRM was the most preferred name for the specialty globally. So 19 countries voted for that name. But what is also interesting is, again, in a way, there is lack of that uniform consensus, that still 12 countries want RM as the name and 10 countries would want to stick on to PM&R. So it's going to be a huge challenge for everyone to actually agree on a name, which I think really is critical for that branding and that uniformity across countries. A rehab physician was a preferred name for the specialist. Some of you might know there is a term called physiatrist, which is used in the States, which is very popular there, but it's restricted only to the States. It's not used elsewhere. And we also agree, as what colleagues said in this survey, that it's a little bit confusing. That term could be a psychiatrist as well. So we would like to stick to the term rehab physician or a PRM physician. In terms of scope of practice, we asked the countries, what could be the key areas the specialty should practice on. And you could see it's not a surprise that MSK, neuro, pain, elderly health, and pediatric health are really the big areas where we want to focus on, but also not to lose sight of other areas like burns, cardiac health, pulmonary health, and others. Conscious of the time, hopefully finish in the next 10 minutes. So we've done quite a lot of all this rebranding work, changing our name, changing our outlook, aligning ourselves with the European Society, the International Society. We've been reaching out more to the medical students so that they're more aware of the specialty. And the good news is actually our numbers, we continue to expand in terms of numbers. This is a recent graph there that actually, in terms of our membership, we've gone threefold in the last couple of years. NHS England actually asked us to host the post-COVID society because of all the work we've been doing in long COVID, and that brought in another new 500 members. And now we've also become multidisciplinary. We have lots of other disciplines also as members of a society, which is again ideal because that's the way we work in. We work in teams, but at the same time, we want to maintain the identity that we are the physicians or the medics in the team. And BSPRM would continue to champion that cause, that it is primarily a medical specialty, but other disciplines are more than welcome to attend, to become members and be part of us. We were very successful in the bid to host the World Congress of Neuro Rehab in 2030, which will happen in Glasgow, and that'll be the first international conference of its kind. We will be hosting as a specialty. So that's a huge thing for us to actually host an international conference. And we continue to influence in policy both nationally and globally. We provide input to various other societies, medical societies, in term when there is any kind of guidance on an area which is related to long-term care and rehabilitation. We work very closely with NHS England, as I said, and they actually very kindly gave us this grant to fund to start the Long COVID Society. We're very closely involved with NIHR, and our colleagues have roles within NIHR. I myself am the specialty lead for MSK, as I said, and also our links with the World Health Organization. The WHO policies are the key driving principles really for our society. And again, we also contribute in terms of their policies. There's a quick video to play here about 2030. So Rehab 2030 is a WHO initiative which basically aims at every individual across the globe having access to quality rehab, whichever condition they have and whichever part of the healthcare system they're sitting in, whether it's primary care, secondary care, tertiary care, that there's quality rehab, and you give the best chance for every individual to improve function and have the best possible outcome from a health condition. And that is predominantly almost 1/3 of the population actually have rehab needs. And this is where the huge gap at the moment is, that we've identified there's a huge need with almost 1/3 of the population globally needing rehab, because everyone have long-term conditions, life expectancy is raising, but there is lack of professionals to deliver that, and especially as we've seen in terms of the medical specialty, we have a crisis in hand.
Rehabilitation. It restores the ability to move, think, see, and communicate. In the 21st century, health systems are confronted with new challenges. With global aging populations and an increased number of people with chronic conditions, more people are living with disability than ever before. For health systems, this means a shift in services that don't just reduce mortality, but improve functioning and quality of life. And this is what rehabilitation is all about. As countries develop and health services improve, rehabilitation is needed to make sure people get the best possible outcome after an injury or illness. It means getting out of the hospital sooner, with less risk of complications and less need for ongoing support. But in many parts of the world, people don't have access to the rehabilitation services they need. Insufficient numbers of trained rehabilitation practitioners, lack of services, and barriers to access, such as high out-of-pocket expenses, are challenges we have to address. Rehabilitation is key for the health of populations in the 21st century. Now, more than ever, we need to take action to ensure that everyone can access quality, affordable rehabilitation services.
So WHO basically puts forward 10 areas of action we need to be focused on. Leadership is very important, very crucial to set the vision of how do you achieve that sort of rehab being an integral pathway in the health system. We need to plan that it is seamless and it includes actually acute care and emergency care services. So rehab basically starts from there. And it's properly integrated across the pathway, and it's integrated into the healthcare sector beyond the hospitals. Rehab needs to become part of the universal health coverage, and it will become an essential metric which every hospital or every health unit needs to report on. The service models we've talked about, workforce is critical, as we said. So there is a need, and we have a framework, but we need more trained rehab professionals, not just medics. Every other professionals, there's a global shortage, particularly in the low and middle income countries, as you saw in the video just played. Um, um, Governments need to ring fence budgets particularly for rehab, because any initiative you can see money coming into the trust, it gets actually utilized pretty much in the acute sector, and there's hardly any money reaching rehab. So if rehab has to become an essential component of the universal health coverage and a metric and a key health indicator, then we need ring fence budgets to support that activity. And data is very important. As we said, how do you assess functioning? For that, you need data, you need outcome measures which can measure function, and you can report on that. And research, again, is a key element. Without research, you can't move that whole field forward. And again, this is multidisciplinary research and basic science, clinical delivery, outcomes and pathways and health services. And this can happen only with networks and partnerships, not only in the country, outside the country, and globally. This is a piece of work we did around this WHO's 2030 initiative in BMJ, calling for how do you strengthen rehab in health systems. So WHO's World Health Assembly in 2023 passed this resolution and that was the first resolution of its kind actually passed in WHO, agreeing to strengthen rehab in health systems, and that has never happened before in terms of prioritizing rehab in health systems. So this is the time to actually work on developing that workforce and that strategy in our healthcare systems to champion for rehab and give the best for the patients who are in need. And where does that leave us in terms of our future? I think we have the plan. We've set out our roadmap for the specialty and for the society. We will, as it's very encouraging to see that within a couple of years, we're starting to expand in numbers and scope, and hope that continues. International equivalence is key. We have a lot to learn from our colleagues, and they are basically our inspiration, and they provide the template for us to continue to grow. WHO is providing all that sort of visionary framework for us to sort of grow into. And something which is quite unique to the UK situation is actually the work which is done by medics is also done by many other professionals and disciplines, and it is good. It is good to see that sort of interdisciplinary working, but it's worrying that sometimes and in some situations that has actually even eliminated the need for a medic, and I think that is not good for the future of rehab, for the future of the specialty, that we continue to work with them, but then we have our own space, and we need to make sure that a doctor doesn't get kind of substituted by some other professional in the team, because that is not good for the patient. And we need to understand the patients need the specialty. They need the specialty globally. So UK can't be any different. If we want to claim to have a healthcare system which is as good as the rest of the world, I think we need to champion, we need to protect, we need to provide all the support needed, especially given the problem we have and the crisis we have in terms of reduced workforce, that we are allowed to grow, we are allowed to expand, catch up with the rest of the world. And at the end of the day, it's all it will translate into care. If we invest in the specialty, the patients are going to be the eventual beneficiaries. Thank you very much, and hope you enjoy the rest of the symposium. Thank you so much.